Recording. Welcome to our presentation, Managing Hospice Care Organizations by
Joseph Baraza.
I'm Sterling Harris.
And Brittany Reber.
What is hospice and hospice care? A hospice is a nursing home, hospital, sanitarium, convalescent home, or a special hospital that specializes in caring for the terminally ill patients who are dying, where their practical and emotional needs are dealt with, as well as their medical needs. Hospice care is a special kind of care that focuses on the quality of life for people who are experiencing an advanced, life-limiting illness. It provides a compassionate care for people in the last phases of incurable diseases so that they may live as fully and comfortable as possible. Hospice care emphasizes pain control and emotional support for their patients and sometimes refraining from taking extraordinary measures to prolong life.
Next.
Next slide. What is palliative care? The word palliative means medical treatment that relieves suffering without treating the cause of the suffering. A palliative is an action that is intended to make the effects of a problem less severe, but does not actually solve the problem. Therefore, palliative care is aimed at optimizing the quality of life and mitigating suffering among people with serious, complex illness. Therefore, doctors can provide treatment to seriously ill patients in the hopes of a cure for as long as possible. Those patients may also receive medical care for their symptoms or palliative care along with curative treatment. Next slide.
Good.
Who can benefit from palliative care? Palliative care is a resource for anyone living with a serious illness such as heart failure, chronic obstructive pulmonary disease, cancer, dementia, Parkinson's disease, and many others. Palliative care can help patients understand their choices for medical. So what is the difference between palliative and hospice care? Hospice care is comfort care without curative intent. This means that the patient no longer has curative options or has chosen not to pursue treatment because the side effects outweigh the benefits. Palliative care is comfort care without or with curative intent. Next slide. So the description of hospice care segment in the industry. Across the United States, over 5,500 hospice in the organizations provide medical services for pain management. They also lend emotional support and offer spiritual resources and therapies as patients enter the last stage of their life. The top 5 diagnoses include cancer, dementia, heart disease, and lung disease, and these account for over 83% of patients. Among them, cancer is the largest category, accounting for 36.9% of patients. Hospice is now a $19 billion industry, and it's almost entirely funded by taxpayers. It is a lucrative business and is the most profitable type of healthcare service that Medicare pays for. In 2018, 1.55 million patients were taken through hospice services in the United States, and in the same year, 34% of the hospice patients were older than 85 years old. And across the United States, 54.7% of full-time employees in hospices are registered nurses, ADs or volunteers, and over 55% of hospices are for-profit organizations, while 29.7% of hospice care services classified as non-profit. Next slide. So the organization structure of a typical hospice care. gave an example of a Wakefield Hospice organizational structure. On the very top, they have the board of trustees. And then below the board of trustees, we have the CEO, who is in charge of the medical director, the director of clinical services, the director of finance, the director of fundraising or retail operations. And then all the other structures, they fall under the directors, such as the medical staff, the finance manager, facilities managers, admin assistants, all the way to the very bottom level. Next slide. So what professional advocacy organizations represent the hospice segment of the healthcare industry? The first one is the National Hospice and Palliative Care Organization. It is the oldest and then largest non-profit member organization representing hospice and palliative care programs and professionals in the United States. NHPCO collaborates with other end-life organizations and offers memberships to hospice organizations, palliative care programs, bereavement centers, education, research organizations, foundations, home health agencies, companion services, medical supply companies, pharmaceuticals, staffing agencies, and healthcare accountants and healthcare consultants. Sorry. NHPCO represents over 80% of hospices in all 50 states, the District of Columbia, the Virgin Islands, Puerto Rico, and Guam. Next. The other professional advocacy organization is the National Association for Home Care and Hospice, also known as the NAHC. It is an association for providers of hospice care in the United States, and it's based in Washington, D.C. It represents 33,000 home care and hospice organizations. It supports the Home Care for Seniors Act, which was introduced in the House of Representatives in 2018. And it allows seniors to use funds from health savings accounts for qualified home care services. The NAHC mission statement is to promote, protect, and advance the highest quality and unifying voice for home care and hospice. The third professional advocacy organization is the American Academy of Hospice and Palliative Medicine. It is a professional organization for physicians specializing in hospice and palliative medicine. And the organization is based in Chicago, Illinois. Their membership is open to all healthcare providers committed to improving the care of patients with serious or life-threatening illness. It has more than 5,200 members, 82%, and 6% are residents or students. AAHPM tracks critical issues and provides members with information, tools, and training required to be effective advocates for their patients and their practice. The other professional advocacy organization is Hospice Foundation of America. It's founded in 1982. Their mission is to provide leadership in the development and application of hospice and its philosophy of care for terminally ill people with the goal of enhancing the American health system and the role of hospice within it. HFA also provides professional educational programs to its members on various subjects and topics.
So, the history of palliative care. The Latin word hospice means traveling guest or traveler's host. In the 11th century, crusaders were the first to create the hospice for travelers and crusaders who were ill. In the 14th century, knights also gave homes to the incurable for a place for refugees and travelers. A majority of hospices created were through religious groups. For a few centuries, hospice disappeared along with the religious groups that had created them. In the 18th century, a sisters Irish group created a hospice for those of one or two similar diagnoses, specifically tuberculosis and cancer. They were called the Sisters of Charity, who originated in Dublin in 1879. They created many hospice groups in other countries. And in the 20th century, it wasn't until then that palliative care specifically came into existence despite medical care being around for generations. The forward thinking of Cicely Saunders, a British nurse and social worker who devoted her life to caring for terminally ill, she developed the first modern hospice in 1967 at St. Christopher's in London. Saunders spoke at Yale in 1963. She gave a lecture that detailed holistic care and the potential on aggressive symptom control during the last days of life. This lecture and many other factors led to the development of hospice and palliative medicine in the United States specifically. In 1969, Elizabeth Kubler-Ross wrote a book that was published called On Death and Dying. The book detailed 5 stages that terminal patients go through while progressing to the end of their lives. Kubler gave their testimony before the U.S. Senate in 1972 on recommendations for final care at home. Throughout the 1970s, this led to the United States from a volunteer based movement to a new medical specialty. And in 1974, a bill suggesting Medicare should pay for hospice was rejected by Congress. Fortunately, though, in 1978, a task force determined that hospice was a concept that could improve end of life care and decrease Medicare expenses. The method that proved this was that there were 26 hospice programs across the USA that were used to measure the effectiveness of the approach, and that led Congress to create a hospice benefit in 1982. The Medicare benefits provided per diem payments for the care of patients who receive referrals by 2 physicians. That said, the patient would die within 6 months when their illness follows its natural course. Once getting hospice benefits and that patient signs off the rights to receive hospitalization, hospice agency will provide them care. If patient lives longer than 6 months, that patient has to go through the process of certification for hospitalization and other treatment options, unless it is projected that they will die in less than 2 or 3 months. Where hospice care is delivered, a patient's home, freestanding facilities and clinics, hospital outpatient facilities, nursing homes, and other long-term care facilities. All are dependent upon where the patient or family prefers for them to live out the remainder of their life. Patients that have a referral for palliative care usually receive the care, from home or a residential setting. Um,
Hospice care is reimbursed through Medicare. Medicare benefits are available for those on hospice when they forego curative treatments for their terminal condition. Medicare will continue to cover the costs of services and items that are outside of hospice, and that per diem or per day reimbursement is the same regardless of if there's a few services provided or many services provided. And just a few of the benefits that are included are skilled nursing services, drugs for pain control, physical, occupational speech therapy, counseling, whether that's dietary, spiritual, family bereavement, and a home health aid. Again, Medicare reimburses at a daily rate. Payments are made according to a fee schedule that's based on 4 different levels of care. So there's routine home care, which is the most common type of care. It accounts for 95% of all hospice care. There's continuous home care, inpatient respite care, and general inpatient care. And the 4 levels are distinguished by the location and the intensity of the services provided. And on the right-hand side, there's a little chart that kind of gives a basic average cost per day for each of the 4 levels of care. Next slide. Medicaid does play a role in regulating and reimbursing hospice care. Individual states are responsible for creating the guidelines and the standards for agencies who are going to contract with hospice services through Medicare or Medicaid. CMS defines what hospice care is, and then the CMS also defines what services are covered. This comes out every year. It's called the final rule. It finalizes any payment updates, any changes to the hospice wage index, and then payments are dispersed based off of this final rule.
So principal managerial challenges. So we found that in the challenges that can happen are inadequate training for clinicians. So in terms of difficult conversations for end-of-life care, only around 18% of students and residents receive formal training in end-of-life care. 40% of residents felt unprepared to teach end-of-life care to younger clinicians. Difficulty with comforting the family or patient that may be trying to come to terms with reality. And this came from the NIH website. Insufficient compensation. Physicians giving end of life care often do more cognitive work than procedural, because procedural you're billed per like units and procedure when they're not equally compensated, considering they spend more time counseling and fulfilling an altruistic need of giving relief to suffering of the individual and family members. Personal discomfort with death. Some physicians view death as a failure or as an enemy instead of a natural part of life. A dying patient can often remind the physician of similar losses they have personally experienced, leading to strong personal feelings for a patient that can delay referral or palliative care. So staffing, even though it's end of a patient's life, it doesn't mean that they don't need good quality of life in their remaining days. Clinicians can feel as though there's nothing to be done. There may be less sense of urgency in giving care. Staff to patient ratio may be unequal for workload required during, depending on the facility and state guidelines, has been seen at that some facilities will meet the bare minimum of staffing requirements in order to make a profit. I've personally witnessed this as a CNA. General issues to each type of facility, medical issues. So these all actually go into like kind of a whole. They coincide with each other. So late referrals, according to the Veterans Administration in 2012, has found that patients did not receive palliative consult until 38 days before death, and then receive care from home or in a residential facility 20 days before death. So 38 days before death, they got the referral, and then 20 days they get the care. Palliative care is not available to everyone with a serious chronic illness. Only 1/3 of hospitals with more than 50 beds have a palliative care team. Double effect and the use of opioids and sedation. This is something that I caught my eye when doing this project. NIH says that opioids and sedatives provide effective relief for patients in distress from symptoms of pain as the end of life approaches. There's a misconception among professionals that the life of a patient may be shortened by increasing the dose of drugs in line with accepted clinical practice. This belief is very often shared by patients and sometimes the family. The DDE provided justification for action, such as an increase in opioid doses, that the professional foresees may shorten life, but does not intend to have the result is justified, provided that the intention is to benefit the patient and not shorten their life. In the classic interpretation, a patient is in pain, a higher dose of opioid is given to relieve that pain. But at the same time, in the belief that this may shorten life, that this traditional argument that increasing opioids and sedatives when used in line with best practice really requires such high doses as to risk shortening life. So something to do if you're an administrator is to encourage the clinicians to always track dosage, other meds being given, and be sure a clinician is never giving doses outside of the required and recommended practices. If they are, it will not be protected under the DDE. Issues to the type of facility continued. Legal, those getting referrals or coverage from insurance really has to be within the grounds of medical necessity to receive care. They're usually a requirement when receiving palliative care through insurance. When getting palliative care, authorization is a requirement. There are specific medical criteria to meet when requesting hospice. Examples are report of frequent hospitalizations in the past 6 months, terminal diagnosis that will end of life in 6 months or less, progressive weight loss, and increased fatigue or weakness. So these are things that if someone's coming in, they're going to die. So you got to make sure everything's in line with this. Ethical, keeping patients' dignity and wishes while delivering end-of-life care. There's sometimes a reluctance in giving a referral because some physicians see it as, like I've said earlier, abandonment and failure. But it's what's best for the suffering patient and within a manageable disease. I'm so sorry. Families may also be reluctant, and the patient may be ready for the palliative care, but the family could keep them from being comfortable in their last days. Causing or prolonging a miserable quality of life is actually tort. And CPR. So this CPR, this is considered in advanced care planning. So when someone goes in for palliative care or hospice, you can't really do advanced care planning because It's not realistic for their treatment. Speaking with the patient about planning for their death would be better to discuss, since asking about receiving CPR can instill false hope and a form of denial for their treatment diagnosis. It's not realistic. According to NIH, it is recommended to have the patient involved based on their cognitive state and whether or not it will cause distress. For example, withholding terminal diagnosis is unacceptable if a cognitive state of patient is where they can understand. Going over recommended course of action is better than asking about advanced directives if that causes additional distress, which should be avoided, and also based on the capacity of that patient. Facility issues continued, the patient's home. So these are things that can come up in different facilities. So in a patient's home, there's less supervision. So elder abuse, neglect, and these are led by inadequate nurses or caregivers, poor management, cultural difficulties. Freestanding hospices, facilities, advanced directives, lack of job satisfaction or short staffing, location may be hard to find. In terms of like marketing, lack of sources or referral information is available because they're kind of hidden, not easy to find. Hospitals, when getting palliative care in a hospital, is usually a comfort for the ill and pain reduction, as we know. Issues can be denial of procedures like x-rays and diagnostic testing, because that's not realistic if you already know what's going on. Hospitalization is usually discouraged for hospice patients. Lots of the staff in the hospital can create gaps in communication if notes are not charted, timely manner, things like logistic things like that. There might not be an adequately trained team for palliative care. There are usually not more than 50 beds dedicated for palliative care or hospice. Along with that, advanced directives may not be followed if not documented in a timely manner. So they might accidentally give CPR, you never know. Nursing homes and other long-term care facilities, short staffing, lack of time management, no accountability leads to abuse or tort. Staff may not be adequate in talking to family or patients about end-of-life care or meeting their needs. And a factor of all facilities are obviously, like I've touched on, is advanced directives, correctly following those, respecting the patient's wishes, keeping their dignity intact, having a policy and procedure to follow that makes sense for each case, confirming that everyone is thoroughly following the care plan, recorded events properly, meeting regularly, making sure that people are meeting regularly with each clinician to check their well-being, make sure there's communication. These are just solutions to potential problems. Respecting autonomy is not asking the patient to really make choices, but explaining and distinguishing the consequences of each choices to avoid coercion. And yeah, those are just things too that facilities can have issues with if there's not clear communication and a plan, which as admins, we will have to make sure that these things are followed.
So there are 4 levels of hospice care as defined by Medicare. The first level is the routine home care, and it's the basic level of hospice care, which is provided at home and is also provided in an assisted living facility or in a nursing home. The second one is the level 2, and it's called continuous home care. And it refers to when a nurse stays in a home of a patient for an extended period of time. And this is especially if the patient is experiencing a medical crisis and severe symptoms such as relieved pain, shortness of breath. And however, during this medical crisis like this, the hospice physician or a nurse may decide to address the patient's needs. Level 3 is the general inpatient care. And the goal of the inpatient hospice care is to control severe pain and symptoms so that the patient can return home to their family and familiar surroundings. If possible, the patient may resume routine hospice care at home. An advanced level of care that is more effectively is provided during a short stay in an inpatient hospice facility when the patient is experiencing severe pain or other severe symptoms. And the last level is level 4, and it's called the respite care. And the respite care is a level of hospice care that can only be provided at a Medicare certified inpatient hospice facility, a hospital, or a skilled nursing facility that has the ability to provide 24-hour care to patients who need round-the-clock nursing care.
The next few slides are some hospice organization examples. This is a home health agency called Heritage Home Health and Hospice. They have locations in Pocatello and Twin Falls, Idaho. They have a team of physicians, social workers, chaplains, RNs, CNAs, and trained volunteers that provide support to patients and their families. So many hospice home health agencies offer hospice services like routine care, medical supplies, personalized pain management plans, one-on-one counseling, grief support, education, and sometimes even a short stay in a nursing facility. Next slide. Another home health organization is the Hospice of Eastern Idaho. It's an award-winning nonprofit hospice organization in Idaho Falls, Idaho. This is not a home health agency. It's actually just a hospice organization. So they're the longest running hospice in Southeast Idaho. They boast exceptional end-of-life care regardless of a client's ability to pay, although they do accept and work with Medicare and Medicaid and even private insurances. There is a short video that you guys can watch at your leisure about the Hospice of Eastern Idaho and the services that they offer. Next slide.
Oh, it was gonna play.
Oh, it's like 5 minutes long, so we can.
There you go.
Yeah. Managing hospice care organizations. The CEO or the manager of a hospice care organization, their duties include supervising staff, establishing goals, reviewing documents such as the policies and procedures, contracts, patient documents, and ensuring state compliance. And in some cases, you'll even develop and oversee the hospice budget, deal with billing, and any charitable giving. The rewards and challenges of being a manager or an administrator in a hospice care organization. Staff achievements. So a quote that I found was, "My role is to help my staff feel successful. Success means when the patients are comfortable, their symptoms are managed, and the family feels supported." Another reward is end-of-life care. The reward is the satisfaction knowing that you've been able to help people at a time in their lives when they're very vulnerable and scared. It's such a positive experience. But some of the challenges are the actual physical demands of patient care. So it's 24-hour care. So you have 24-hour staffing and all that goes with caring for someone who is nearing the end of their life. Another challenge is keeping up with government regulations. The challenge is to be able to meet the needs of patients and their families, especially when there may be times that the law doesn't allow it. So next slide. In conclusion, people see a negative working in hospice because all you do is work with dying people. And it's not that it's easy to work with dying people, but you know that your patient never felt deserted and that there was someone there to be his advocate. You know your patient was comforted by the fact that his loved ones are going to be supported even after he's gone. It's rewarding. So I think, over the course of our slides, you were able to see kind of the history, how it's evolved, the Medicare and Medicaid standards, what's required to be an administrator or work in a hospice care organization. And while hospice care, many times can kind of be seen or viewed as a negative, something that people don't want to work with because there is no chance of these people recovering. I think that there is a beauty and a reward in helping someone have a really high quality at the very end of their life. So I hope you guys enjoyed our presentation and were able to learn a lot following our references.